Okay. Hello, everybody. Thank you so much for joining Pre-Health Shadowing. We are an international student-led nonprofit for medical advancement. So throughout this session, we have closed captions to accommodate the needs of all students. And if you have any other ideas on how we can be more accessible, we're more than open to suggestions. Just email us at info@prehealthshadowing.com. Also, make sure that you save us as a contact and keep us out of spam so you can get our newsletters. Other than this, if you want to stay in the loop, other than our email list, you can always follow us on social media. And here are our handles. And we host students from all over the world. And I'm calling from San Jose. And I'd love to know where you guys are calling from. Just feel free to type it in the chat. Augusta, Virginia, Indiana, San Francisco. Another San Francisco, Toronto. Oh, wow. Thank you guys. Other than this, if you're interested in being part of the pre-health shadowing team, you can do so by registering as a volunteer. This is 100% remote, so you can do it from the comfort of your own home. And if you'd like to take things on the next step, we're also recruiting, so you can apply to join our leadership team through the link in the chat or on our website. And here are some of the available roles that we have. And other than this, if you think that there's another role that's not listed here, but you think it would be a good addition to our team, we're always open to suggestions, and you can apply using this link in the chat. Other than this, if you are a high school student, well, good for you. We are hosting a high school training program called HTP, and it's offering leadership and healthcare education for pre-college learners. To this, you can just fill out the interest form. Other than this, we run solely of the time and donations of our volunteers. So it would be really great if you guys could consider donating to our program, even if it's like $1, or you could donate by volunteering your valuable time with us. Throughout this session, you will have the opportunity to ask questions to our professional Dr. Rodriguez. So you can type your questions in the chat or raise your hand, and our co-host will ask them during the Q&A session. Make sure you take good notes throughout the session because our post-shadowing assessment will be available to take a digital certificate that verifies your hours, and it's available on the pre-health shadowing website. Other than this, it would be really great if you guys could turn on your camera because we're trying to replicate a real life scenario right here, and it would just make the session more engaging. Thank you so much for joining, and now I'll pass it on to Dr. Rodriguez.
Fantastic. I would like to um, on the chat. I'm typing my email and my contact phone number for everybody to have it. Okay. I would like to know also if you guys can see the screen in front of me. This is my website. Could you tell me if you can see the screen?
Not right now. You'd have to share it through Zoom.
Okay, let's do that. Mm, Let's do this right now. Let me know if you can see the screen, please. Perfect.
Yeah,
So, okay, so that's my website and my webpage. A reason why I want to start with that is so you guys can understand a little bit about. I practice in Chicago, Illinois. I'm at Ascension Saint Joseph Hospital. It's on Lincoln Park. Is for those who have not been in Chicago. Is a neighborhood just north of downtown Chicago. It's about 5 minutes from downtown. It's part of Ascension Healthcare, and anyone that is interested to do some shadowing, email me and I will do anything possible to see if you can come in and shadow clinic, any other physician, surgeon, meet with the surgical residents, so you guys can have a good interaction. If you go to my website, Dr. Edgardo you can see a bit of what is the emphasis of my practice is complex deformity correction, which means individuals that, children or adults, that they have limbs that are just abnormal length, short, angulated, rotated. I did some additional training in Europe on how to correct and realign limbs. I also am involved in patients that have nerve injuries, um, either by trauma, car accident, motorcycle accident, cycling injury, skateboarding. There's a lot of scooters in the city, which that's really good for my surgical residents because that keeps them busy in the OR. Not good for the patient because they do suffer a lot with these scooters. And I'm not a fan of anything anything high risk because of what I do for living. But if you scroll down on my website, you can see a bit of like I'm a board certified reconstructive podiatric surgeon for 25 years. I'm a member of the Department of Surgery and a board member and fellow of the Association of Extremity Nerve Surgeons. It happened to be that I'm the founder and chairman of the Chicago Lower Extremity Surgical Foundation. Next year, we're going to be celebrating our 20th year anniversary of the foundation. We have a national meeting in Dallas, um, in which we have surgeons coming from all over the world to learn the latest techniques of what is called lower extremity reconstruction. I'm the director of the fellowship program at the hospital. I'm also the associate program director for the Podiatric Surgical Residency. And I go to Latin America constantly, at least 6, 7 times, to help with patients that they have congenital deformity, birth defects. Also, probably some of you guys may know the amount of motorcycle injuries in Latin America is unreal. And obviously, a lot of these patients, they end up with bone infection, really bad fractures that they suffer from long, chronic term infections and multiple surgeries. But also, if you go into my website, it kind of goes over some of the things that my practice offers. But one that I really am very passionate about it is basically the one that says paralysis dropout. Patients that they are born or they have injuries and they have a limb that doesn't move, how to reconnect the nerve that they can have better function, etc. And in the website, you can also have basically some case studies and also some videos. This is a child that you can see has some difficulty walking, had a motor MTV injury that affect the nerve around the leg. And I did what is called a nerve procedure to restart the function of the extremity. And we see patients from all over the country and with this type of specific injuries. In the bottom, there's some additional videos that you guys can see so you can understand what's really podiatric medicine surgery. It's a medical surgical field, obviously, and I'm gonna go over some of really what's really about on when it comes to requirements and things like that. I'm not gonna get really picky on the requirements, specific requirements, but overall, you are dealing with a medical career to be a physician and a surgeon. and all careers that are medical surgical that lead to be part of the Department of Surgery, oral surgery, podiatric surgery, any type of allopathic or osteopathic surgeon, we train in hospital. The total number of years of training is 7 years of training. Most of our podiatric medical surgical residents is getting more and more popular, an additional year of fellowship. So that means 8 years of training after you're done with your college. You do need to have MCAT score. You have to have letters of recommendation. You do have to have an interview process. They take a look at your GPA, general GPA, your science GPA, but email me so I can put you in contact with Miss Kim Young because she's just excellent putting you in contact with a faculty member. What else I can tell you? Scholarships, plan a visit to the university, etc., etc. It's 4 years of training in the Chicagoland. Then from there, you move to your residency program that it could be in Chicago or any other hospital outside of the Chicagoland. And then the fellowship program are in the US with some, like ours, has some rotation in Europe to be the most complete lower extremity musculoskeletal surgeon. Okay. The We talk about this already. What exactly are the when it comes to the scope of practice, it all across the country, obviously your training is going to be equivalent to do anything on the lower extremity. By the same token, because you're a surgeon, you need to know all these basic courses and medical courses to try to understand overall health. You had to involve in management of antibiotics, management of other medical conditions, obviously collaborate uh, with other medical physicians in the hospital. We do have and we do part of medical emergencies. Patients like this one that you see that has, I don't know, you guys can see it, some bubbles that in the top of the foot, and then right here along the side of the leg. This is gas forming bacteria. If you get called from the emergency room and you don't take care of this patient immediately in the OR, this patient could die. So we do have medical emergency. For the most part are infections. When it comes to fractures of the lower extremity, we share what is called share call with the orthopedic service. Same way that the orthopedic service share calls with the plastic surgical service for hand injuries. We do have overlap with other services, especially orthopedics for bone trauma. Okay. Very, very important. Fracture care, as something as simple as fractures around the ankle, elective foot surgery, same way that in the hand you can have joint contractures, tendon ruptures. The same thing happens in the foot. But we also get involved even in cases that are more complicated, which my residents they love to be involved with. This is a patient had a leg fracture. The device that you could see on top of the leg is called an external fixator. And then we basically are involved in what is called bone lengthening procedures. It's fascinating. This is actually one of also another one of my case. Uh, this is me right here on the right side, and this is one of my surgical resin. And I'm gonna press the video so you guys can see a little bit about what is really happening here. And basically, I'm stimulating the nerves around the knee to figure out which nerves are compromised or affected so then I can repair the ones that are not functioning. That is called intraoperative nerve stimulation. I'm using what is called magnifying glasses. Why? Because nerves are really tiny and you have to really kind of have a really good knowledge of your anatomy. As part of your podiatric medical training, you had to do gross anatomy, which is the entire body, obviously. And you do those courses with the allopathic medical students. But then also you go into specialty courses, like is an additional lower extremity anatomy that is significantly more in detail than for the general allopathic physicians. Uh, when we look into these images, and I hope that you guys don't get grossed out, this is an amputation of the lower extremity, just above the level of the ankle. Even though we try to save limbs a lot, we share what is called responsibilities on patients that require amputations with the vascular surgical team. So we do amputation of the extremity, although we are basically always trying to maintain and save the limbs. Uh, if we proceed with an amputation, the amputation that we like to perform in our service is the one that is for sensor prosthesis, that when the patient thinks, the prosthesis will move. Ascension Saint Joseph Hospital and Northwestern Memorial are basically the only three hospitals in Chicago that perform what is called the phantom-free amputation. This video is fascinating because you guys can see when the patient thinking about moving the foot up, the stump move up. And how this happen is basically the nerve, I place the nerve in the muscles that they're supposed to be. I don't let those nerves just go everywhere. And the sensors of the prosthesis are placed in very specific area where the numbers are in the diagram. And it's really amazing. And these are just patients that I have done this type of amputation in which you can see, you can hardly notice any type of abnormalities on how they walk. And then we have this lady also that even walking at her age with other problems in her back and hip, she can move around with this type of amputation. So don't think for a minute that all amputations are bad. An amputation that is well done is a great procedure for a lot of patients, okay? What we see in here is a patient that was referred to our service with a wound in the back of the heel. The patient had an Achilles tendon rupture, developed an infection, multiple problems. On top of that, he was a heavy smoker, and smokers don't heal right. So what you're seeing is basically a drawing on the leg. That drawing, basically what it represents is an area of the skin that I grab from the leg and I rotate and I pivot in an area where there's really good blood flow to cover that hole. That is called flap reconstruction. So our residents that get trained in plastics, and this is a plastic surgical technique that we learn because what? We are basically, as when you finish, all this is part of your training. This is how the wound from before to after, and then basically we can see now how the patient can wear the shoe and how um, the patient can function after the extremity have been saved. Because when you have this infection that they last for a long time, that the infection that eats up the bone. And when that happens, some of the options that we provide to the patient is an amputation. This is basically an external fixator, the same thing I use for this patient leg, okay? It goes around the leg, and we also use this type of device on patients that are born with crooked limbs at birth, or they have an injury or a fracture and it heals bad. Those are called malunions. And this is a device that it gets attached. It has some how you say measurements, and you enter basically some important information that is in each bar into a computer system, and the computer will basically tell the patient how they have to manipulate the device to get a corrected limb. So in reality, podiatric surgeons can work on a private practice. They can work for a hospital, teaching hospital. I work in a hospital, and I'm also part of a teaching program at the hospital and also at the Podiatric Medical School in Chicago. Obviously, you get paid to the insurance, what is called the HMO, PPOs, but also there's some physicians, colleagues of mine that at the end of their career, they work for insurance company, helping out with reviewing claims and assisting administrative type of position. You could work for the military as a military surgeon. You had to reach out to me, and I can tell you specifics. There's some very unique, specific Army, Navy, and Air Force, and all that. So I just don't know all the specific, but I can put you in contact with that person that knows all the ins and outs. You can work for a medical school. I have a position with a medical school, Rosalind Franklin Medical Center, and you can work for the government. The government will be a VA, the Veterans Administration. When you group your specialty that you're trained, you have to really be very general also. If someone comes with a superficial or very light infection, you need to know if it's infected or not. Sometimes the patient comes with both limbs are, swollen. Well, you need to know that maybe they have problem with their kidneys or liver, and it's something more abdominal organ related. So you have to know medicine. We basically have to deal with fractures, so you do orthopedic surgery. Sports medicine, there's even fellowships in sports medicine. And long time ago, I was part of the team physician for the Chicago Fire soccer team. So you have to really wear a lot of hats when it comes to the lower extremity because of the anatomical territory. In the Chicago school, they're very proud because they have the dean of the school is the first woman that has been inducted to the Hall of Fame, and they have alumni that they are team physicians for all these professional teams. So it's extremely important to really know about that stuff. The college requirements, as you can observe in the screen, all the specifics, like I said, I'm not gonna go into this stuff, but it's a 4-year program. There's short courses with the allopathic medical school students, and we have all type of options for any student that is considering podiatric medicine and surgery a medical career path. It's a specialty on its own. One of the big differences from the allopathic is that when we do our first 4 years, you go into a specialty right away, kind of like dental and to oral surgery. And when you go through the allopathic, osteopathic route, you have to do 4 general years and then go into your specialty, okay? In the contact information, my email, Edgardo.Rodriguez-Collazo @rosalindfranklin.edu, and my cell phone number, and obviously I'm a surgeon, so I will not be replying right away, but if you need something that I can help you, I will put you in contact right away with that person at the school. It's 773-412-8595. The best you can do is just send me a quick text or an email. Tell me what I can do and help you, and I can really, in that way, help you with whatever doubts or concerns you have, etc. The whole purpose of what the reason why I'm doing this is to empower you guys to do better in your selection if you're gonna go into medicine. Why? Physician burnout is real. If you don't like what you do, stress becomes very painful. So I highly recommend you guys to do shadowing. I was accepted to allopathic medical school and podiatric medical school. And I shadow. And if you hear me talking a few times, you're probably going to hear some of the stories twice. When I wrote it with a pediatrician in his office, and I start hearing all the babies crying in the waiting area, I said, "This is not for me," you know. And then when I wrote it in radiology, which is a radiologist is in a room by himself reading X-ray, I said, "This is I cannot do this either." So you have to really look into what you like. Although when you go into the allopathic medical track, it's really hard to know where you're going to end up because you have to do 4 years and you have to do these rotations. So going into the allopathic track and saying, I want to be a surgeon, well, I hope that you can match for surgical training later on. In our field, you go directly to a specialty and you go into podiatric medicine and surgery right away. So that's one of the advantages of our career path, that it takes you to the OR right away if you want to be a surgeon. When I wrote it with a podiatric surgeon in town, I realized that the diversity of treatment options was very appealing. It was not boring. When I wrote it with orthopedists, I liked the concept of bone trauma, but I couldn't imagine just doing bone trauma all the time because as I show you, I do peripheral nerve, I do soft tissue skin procedures. Um, I also wrote it with a general surgeon, and that was the beginning for me, in which I realized I like to be in a surgical a career path. Okay, so keep that in mind. I highly recommend you guys to do some sort of shadowing with us. We do offer what is called virtual shadowing every 2 weeks. Email me and I will put you in contact with Kim Young. And virtual shadowing means that we have a multiple group of surgeons of our field, and they show cases and kind of like an interactive, almost like watching Netflix, in which you can really kind of dive into what it's really like to be us in 2026. Okay. And also give you the opportunity to meet with podiatric medical residents, and they will tell you their frustrations and all that. And it's just very beneficial. Okay. So I strongly recommend it that if you're going to go into medicine, and you want to know more what is podiatric medicine and surgery, and you guys can see I'm not using the term podiatry for a reason, is because they're changing the terminology in all hospitals. Like for instance, in our facility is the Department of Podiatric Surgery within the Department of Surgery. Uh, the school, Podiatric Medicine and Surgery, Georgetown University, Division of Podiatric Surgery, University of Cincinnati. And it's because right now, the terminology, it kind of works better with the type of training we have, and it kind of helps educating the public better. Okay, so keep that in mind. Then, before I proceed to, my God, I'm talking too much. It's half hour already. I would like, if does anyone has any questions for me? Jump in on a chat and let me see how. Um, anyone has any questions for me right now before I just go into? Okay, are there differences in the type of your cases you see international compared to? Yeah, totally. And the reason why is because, like for instance, when I go to Colombia, to the city of Cali, Colombia, they have 500,000 motorcycles. In 1 week, you will see so much trauma that is unreal. In 1 week there, on the amount of trauma, diversity, and complexity may be equivalent to 3 to 4 months in a Chicago hospital. Okay. There's a lot more gunshots in Latin America than in Chicago. So the social economical factors determines a lot on your training. So that's the reason why you have so many of fellowship programs in the US that they have European and Latin American rotations for that purpose, okay? Very important. I have a dear friend of mine that he is taking residence to this year, at the end of this year, depending how things are going to Gaza, to Palestine, and you can imagine. 2 years ago, I did a week of cases in Israel, in a border with Syria, with a surgeon that I know that is an excellent traumatology. So that's extremely important. So it changed a lot, but our residency programs responsibility is to offer you the big picture, and then the fellowship, if you want, you can kind of tailor your training into that level. I will have to tell you, if you want to work for an academic hospital, they do like to have podiatric surgeons that are fellowship trained. So that immediately will obligate you to do 8 years of training. Okay. What else? I am definitely interested in the visual shadowing. So Juan, what you need to do, just email me, and then I will put you in contact with Miss Kim Young, which is great. And then in that way, Juan, where you from, and which state are you calling me? Let's see if you can. Uh, and I just want to keep this a bit Toronto. I have Canada. One of my residents is from right now in the third year. He's from Quebec, and he's planning to work in Maine. Um, and he want to stay in Maine for quite some time, and then all his family's in Quebec, but he want to get his license also in Canada. Not all podiatric surgeons they have the same hospital affiliation and privilege in Canada. In Alberta, Canada is different than Quebec. Uh, the the US is the only country that has podiatric physicians and surgeons. Okay, so keep that in mind that when I go to Latin America and I enter all my credentials, I cannot enter and they accept my credential as a highly specialist in the lower extremity in orthopedics, because the degree itself, it does not really exist outside of the US. Okay, so you keep that in mind. Okay, same way as osteopathic doctors. The osteopathic doctors, that degree doesn't exist outside of the US. Okay. Um, if there's any shadowing opportunity in or near Vancouver, I can set you up in Alberta, Canada. Is one option. Also in Alberta, and also in Seattle. You may have to go to Seattle, and in Seattle I can put you in contact with some surgeons over there that they're fantastic. So email me. I do have some additional colleagues of mine that are Canadian that they practice in Michigan, and I can also put you in contact with them so you can bounce some ideas and all this stuff. Our hospital have trained many Canadian surgeons. What about, what it says here, what about Los Angeles, California? Yes, we have contact Kim Young. We have a great network of alumni that they're all over the country, and she's excellent to plug you guys in with some great mentors that can let you come into the clinic. If they are part of a surgery center, you can come in perhaps and see some cases. Sometimes very difficult, but sometimes it's happened that you can go into the OR in a hospital. It all depends from state to state and different criteria. Uh, what email should we use to contact you? The one that is on the screen, Edgardo Rodriguez-Collazo at rosalindfranklin.edu. Okay, that's the one that you guys should use. Okay. And then I will reply, and then in that way you guys can learn more. I'm trying to empower you guys. Multiple reasons. The university doesn't want to have students that after 2 years they flunk and they fail. The the training is rigorous. It's medicine like any other medical career. You have to study, you have to open the book. And what we have seen is that if you like science and you like the challenge and you can see the end of the tunnel to be a very successful physician with a good income, we want to have good students, obviously. So that's really very, very important. Texas, yeah, obviously, we have some great. Actually, I go to Texas quite a bit to do some training. And in April of this year, I'm gonna be in Texas doing a training for surgeons. Send me an email. Maybe I can get you to see uh, some of the training that we do on cadaveric specimen in a great surgical facility in Louisville, Texas. Okay, in the area of the colony. You can Google it, Orthofix, the Orthofix Academy. They are one of the orthopedic manufacturer companies that they built some of these devices that we use in the OR. Okay. What about, do you ever get to work with any medical teams? Yeah, totally. Yeah, so when you work for a hospital, you're obligated to work with multiple physicians, and I love it. When I go to the doctor's lounge, I may be talking about a patient with infectious disease doctor. At the same time, I bump into the vascular specialist, and hey, when you're gonna do the bypass on that patient's extremity, so I can do the surgery. So we mingle a lot in the hospital. When you're in private practice, you're a little bit more a loner, but you had to mingle anyway. You're going to go to the hospital to do surgery. If you go to an outpatient surgery center that is not part of a hospital, you may be more isolated, but it all depends how you want to practice. I love to practice in a hospital right now, but when I started in private practice. I didn't want to be bothered by hospital stuff. It's a lot of work to be in the hospital and getting things done in a hospital. Why? Because there's too many patients. But if you're in private practice, I think that sometimes it's easier to start growing as a physician, but then later on, working for a hospital is not a bad deal at all. What advice would you give to an incoming freshman interested in medicine? I think that if you get accepted to any of the medical careers, like dental, podiatric medicine, or just allopathic osteopathic medicine, I would tell you that that demonstrates that you have the brain power, that you can memorize stuff, study well, and that you have what is needed. What I see that is a problem sometimes is basically the grit. It's really the performance, the perseverance, the consistency. Because you're gonna fail a lot, but that's how you learn. That's how you're gonna grow. That's how you're gonna feel that being uncomfortable is okay. And if you can absorb, understand, and be cool of being uncomfortable, you're gonna be fine. Quitting right away is not good. Why? Because you don't give yourself to really go through that and then overcome and become, successful later on. So I think, I would say perseverance and grit. Learn how to mingle right away. Try to think about uh, always the future, what exactly you want to be, and I think that you should be fine on that end. But the first 2 years, I'm not gonna sugarcoat it. The first 2 years, you're grinding. You open your book a lot. You have to memorize a lot of testing, because they're preparing you for the last 2 years that you start your clinical hospital rotation. Podiatric medicine and surgery, you have 5 years straight in a hospital. 2 years are basically in the school. Okay, so think about that for a second. If you do a fellowship, it's 6 years in a hospital training. It's not in a physical therapy group, in a outdoor place. It's in a hospital dealing with patients. And when you're dealing with patients, by by definition, you're gonna learn medicine. By definition, you're gonna see everything. During the pandemic, I was involved in all kind of support, even administrative support. Sadly, our hospital converted into a COVID hospital from one day to the other, and I had we saw a lot of people dying around us. I had five of my own patients in 1 month die. So believe me, you're gonna get your hands full, but embrace being uncomfortable, and being a physician, being able to help other people. It's just a blessing, and being in a hospital is a privilege. But you have to really be sure that this concept, and I get asked all the time about balance. Guys, after so much training and so much discipline and dedication, sometimes the balance doesn't happen immediately. Think about it. 13, 14 years of training, you end up with $250,000 in debt. You want to make over $300,000 a year. So that balance is not going to happen by working postal office hours from 9 to 6. So when I have a surgery day, I'm in the hospital before right about 6, and I have to see that patient at the end of the day after I'm done with clinic. I may be home at 7, 8 o'clock at night, but I love it. So it's loving what you do that then the stress of that long day, you don't feel like what a drag. Okay. I think that there's other specialties that are not so hospital based, but more like practice based, like dermatology, that, yeah, you can get home at a very decent time. Why? Because there's no emergency room trauma. You're not going to have anyone coming with gas in their face. They don't even go to the emergency room. There's not even dermatology in the ER call. So, but if you want to be a surgeon and want to have a surgeon salary, you have to operate. You have to see patients in the hospital. You have to see patients before you go to clinic and after clinic. And diabetic infections is on the rise. So it cannot guarantee you that you're going to have a great job and great opportunity in our field, because the further from the heart, the less circulation you have. And when you don't have blood flow in your extremity, an infection can go really nasty. So you have to kind of understand that. Do you notice difference between phantom pain? Yeah, totally. Uh, it- it's a big topic of conversation, and I have a presentation about it right now that I'm going to show you. Delayed TMR, I'm going to talk about that. I'm glad that I'm seeing these kind of questions because I love TMR, and I have a great paper on the Journal of plastic and reconstructive surgery. It's called the PRS. If you put PRS, open PRS, and you put my name, that paper was published last year, and it's my own experience with TMRs, and I'm gonna go over that and amputations. Okay. Juan is on fire here with so many great questions, so that's good. Any other questions other than Juan? Juan, you're asking too many questions. What about anyone else that wants to uh, ask some question? Okay, do child adolescent psychiatrists work with you all? That's for Cameron. I will have to tell you what I have seen is my involvement with psychiatry and psychology is when you have a child that comes to our service that requires surgery, and we want to in some way prepare the child what it's going to be like, the surgery, and not just the surgery, the follow-up and the post-operative care. And if we see in a child that has some kind of mental or cognitive dysfunction, yes, we want to have all the mechanisms to treat that child adequately before, intra-op, and post-op. So yeah, drugs, I don't get involved in pediatric drugs related to central cognitive. No, I don't get involved in that stuff. But if I have a child that is coming to see me and have HDAD, he has some sort of low grade bipolar disorder, or an adult with schizophrenia and all that, I want to have a psychiatry consult, hands down. Okay. So you start collaborating right away. And one of the advantages of being in the hospital that I would just type that on my record, boom, psychiatry goes and see the patient immediately, not a problem. Or you have someone that has some mental dysfunction that come through the emergency room. Give you an example. This 2 weeks ago, we had very cold weather in Chicago, and we have sadly a homeless with a frostbite. And it's not easy to treat someone with frostbite up the way, all the way to their chin, and mid level of their leg, in which you're thinking, okay, what should I do here? How do I keep this patient calm? I'm gonna have to do both limbs amputated. Then all of a sudden they have finger, gangrene. Also, it's a big problem when you have someone that you cannot interact and explain what you're planning to do immediately. So I hope that Cameron, that helps. Okay. Uh, what else? Alejandro, what extracurricular can I do that could help me stand out in medical school? Research. Uh, Research is big. And get involved in some sort of research, volunteering in some sort of medical mission outside the US, medical mission outside of your community, something that shows that you could be a team player, that you have empathy, that you have some level of human kindness. That's very, very good. Obviously, nothing is going to replace having good grades, because you need to learn your science. You need to show in your transcript that you like science. And if, let's say that your GPA is not optimal, but it's good enough, you have to have in your interview, they're going to be asking, well, what happened with that biochemistry class? You're going to have an answer. Well, I was slacking. I was, bar hopping too much. You're going to have to come up with a good answer, obviously. But what I had to say, which I'm glad, is at least at Rosalind Franklin Health University, in which we have allopathic, pharmacy, physical therapy, PA, podiatric medicine, their approach, they call it holistic, that it's not just numbers, GPA, MCAT, okay, two-letter recommendation, you get accepted. They wanna have someone that mentally is healthy, have done a little bit more, a more complete individual, because they have noticed that if you're more overall, more complete, it's gonna be easier for you to go through medical training. Okay. What else here? What is the most rewarding part of podiatry that maybe someone outside of medicine might not realize? Listen, for me, the most rewarding part is I don't get bored, because I may see in a child that is not walking right. Mom is concerned. At the same time, I have an old lady just last week, a sweet lady, 94 years old, came with her two daughters because she was having some pain in her extremity. Everybody have told her that it was arthritis. When I evaluated her, it was really that the blood flow to her extremity was not really optimum, because I use a thermal camera imaging, and if you palpate and try to check for her pulses, they were good, but when I do the thermal imaging, I could tell that her blood flow to the skin was not really good. And then I sent her to the vascular surgery service, and they opened some vessels in her thigh, and she's completely pain free. So being kind of like a detective and being able to help a child and an old lady, and then at the same time, one of my residents called me, hey, we have a trauma, a leg ankle trauma in the emergency room. When could we take this patient to the OR? That diversity is really what I like the most about podiatric medicine and surgery. What else? Yeah, I think I answered everything here. So I do have this presentation. I think it could be very helpful. Let's do this, and you guys can see it's basically a presentation that I want to go over the type of amputation that I perform. Okay, and it's called the Earl type of amputation. And as you can see in the screen, I create like a bone bridge between the tibia and the fibula. And what it does, it prevents some of the chopstick sensation, and then the limb is not painful. Why? Because 72 to 86% of patients that have amputation, they have residual limb pain, and about 20% they have phantom pain. So I like to do this type of amputation, and what I want you guys to see is that I use some techniques that were developed here in Chicago by the chief of the plastic surgical department at Northwestern, Dr. Greg Dumanian, and in which the nerve, once you amputate the limb, if you let those nerve wire completely out, not doing anything, they go crazy. So we basically reassign those nerves to very specific muscle to basically have the nerve in some way restore the muscle in that area. And that's what is called a TMR, target muscle reinnervation. And there's another technique that you will see the diagram. We put a bit of a muscle around the end of the nerve, and that helps to also encapsulate the nerve so then the nerve doesn't come out and create basically a phantom pain. But if we look at this patient, I would like you guys can see, I mean, this is a patient that is had that type of amputation. And I want you guys, now that you have seen the type of amputation I performed, next time you see someone that has a cane and and have had their leg amputated, I can guarantee you that it's not the same type of amputation that I perform. Okay, so I'm trying to train as many surgeons as possible to perform this type of amputation, because what? It's much better for patient, and sometimes we cannot save limb, but we had to do a really good, what is called reconstructive amputation. This is the same patient. I want to show you guys how she can stand up completely functional. And if you're functional, you could be active. If you're active, then you can decrease what is called your cardiovascular demand. In other words, you can stay healthier. I want you guys to see this individual. I mean, no, you can see that he's not he doesn't look like the most fit individual, but he had the same amputation, no assisted devices. He's even holding the door, both hands. He has coffee in both hands, or soda, or probably he drinking soda, which I'm completely against, but he's just functional. Let's go over the type. The 21 centimeters is basically from the knee. That's the level where I will perform the bone cuts. Then I create the bone bridge. This is the tibia, the fibula, and then I put a piece of bone in between, and I secure it with a tiny screw. And this is basically the concept of the RPNI, regenerative peripheral nerve interface. And I'm glad that I'm telling you guys about this stuff. So now, any patient that you see out there that have gangrene or had trauma and they cannot save the limb, give me a call, okay? Because I can put you in contact, or I can let that patient know where they need to go to have a really nice amputation. So I'm trying to debunk the concept of amputation, because most surgeons, including myself, a long time ago, I felt like amputating a limb was like a failure, but that's not the case. Sometimes we need to stop trying and just have patients move on with life. So imagine that I transect one of the nerves that I encounter in the leg. I divide the nerve in three sometimes if it's a large caliber nerve. and I place a little bit of muscle around, and the inside of the nerve that they're called the axons will go into the muscle, and we'll find a way to restore that muscle, and in that way the brain doesn't feel that they have to create a phantom pain. Okay, or you can do what is called the TMR, and the TMR is basically the amputated nerve is the one that is coming right along the side. We amputate at this level, and then we place that nerve that is coming from the top to the bottom. We put it inside the muscle, trying to re-innervate that piece of the muscle that was already denervated at the time of the amputation. And then once that nerve kind of restored the muscle innervation or stimulation, then the brain is gonna realize, okay, that nerve is acting okay. I don't need to send another message to that nerve to go and find a way where to go. And in that process, they create phantom pain. I showed you this diagram already, so I'm gonna jump on that. We call this myoplasty because we had to move different muscles in the leg. The classic amputation is 10 centimeters below the knee. This amputation is 10 centimeters above. So it cannot give you a great opportunity for this patient to have what is called a blade. And a blade, you can even run with the blade. So most of my patients, they have two type of prosthesis. One that they can almost run, be extremely active. The other one is more like for special events, that they can put a nice shoe, etc. So, but the blade is can only be done if the amputation is done right above the ankle instead of right below the knee. Okay, so you guys are getting highly educated here today. Some of the complications, a lot of these patients may have some complications, but our complications I can treat no problem. And this is basically the article that if you guys want to hear a little bit more, you can proceed and learn more about it, okay? Any questions? And I think that I've been talking for an hour, and for me, that's sufficient. If you guys have any questions, I'm more than glad to answer some questions right now. It's 7 o'clock for me. It's 8 o'clock for you guys. So I believe that these sessions they're great for give you great message, but every 2 weeks, if you want to hear more about it, reach out to me and I will put you in contact with the right people that will send you the link and et cetera, et cetera. I got a question here. What motivates you to continue doing global medical work after so many years in practice? I just love it. I love what I do. So if you love what you do and you feel that you can help people outside of Chicago and you have the freedom and the opportunity to do it, why not do it? So I get invited to help, like for instance, at the end of this month, next week, I'm heading to Spain and I will be helping some surgeons in a course over there. Then I come back and I will be at the end of the month in March in Colombia helping some surgeons. Then at the end of April, I'm gonna help some surgeons in Mexico. So I do quite a traveling and I love it. Then I had to go to Dallas to teach a course. So I love it. I feel like I'm in my peak right now when it comes to research, knowledge, etc. But at the same time, I love to have residents around. We do have a fellowship program which I am involved in conducting most of their education. I get it. Another, you briefly mentioned phantom free input and with sensor procedure. How does that change the approach outcome to patient with, oh my God, the patients that, like back again, traditional amputations, 86, 70, 76 to 82% of these patients that have the traditional amputation, they have residual limb pain and phantom pain. And if you have pain after you have your leg amputated, you're not going to be moving. So it's basically you amputate the leg and the patient is not functional anymore. And even with no leg, they feel that they have a leg and it's painful. So it's the worst of the worst. So I strongly encourage anyone that is listening that if you hear someone that is going to have an amputation, just to be sure that they have an amputation done by someone that does this type of reconstructive amputation. For trainees interested in complement, what habits should they develop early in their training? Wake up early. They had to learn that they had to wake up early. So I have seen that my daughter, she's 24 years old. And what I have seen is like she goes to bed too late and she likes to get up late. That doesn't work. And I think that you guys work that way a lot. And I used to get to bed late and wake up, noontime. That doesn't work when you go to graduate school, especially medicine. So you have to start learning to really eat well. It's very important. Why? Because if you eat well, you're gonna be able to maintain your blood sugars stable all day long. You're not gonna crash. You can perform early in the morning. You can perform really good at the end of the day also. So you're not gonna have spikes of insulin that then your performance is gonna be terrible. The older you get, like myself, I'm 56, the more you have to be careful about bad habits. Like for instance, I may have a drink glass of wine here and there, but in the weekend, but during the week, there's no drinks for me or anything like that. So before you get into medical school and if you're gonna try to be a surgeon and all that, have all the drinks that you need to have right now. But don't wait. Afterwards, you're gonna have to really shape up. The other thing is workout. Trying to exercise is gonna help you with your stress level, manage anxiety, etc. Anxiety is basically that you really worry. You're gonna be worried about your rotation. You're gonna be worried about your test. You're gonna be worried about if that surgeon that you rotate with is gonna write you a good letter of recommendation or not. You're gonna be worried about. So trying to manage not being so worried and control it. That means that you're gonna control that anxiety. Exercise is excellent for that. You feel like you're stressed out, go for a run, start lifting some weights. There's no better medication for anxiety or when you feel that things are not going well than exercise, but it requires motivation. So, a big advice I can give you guys is trying to find always in school your A team. 18 people that when they see you that you're not doing that well, they will pick you up. People that if they see that you're kind of slacking a little bit, they're gonna pull you because you may be struggling. You may have a family death. Probably you lost your dog. Probably you miss your girlfriend. Probably you broke up with your girlfriend. Whatever. But you need to move on. You need to continue. So having your A team is very, very important. Always cling to people that are more capable than you. You don't want to be the most capable in the room. You don't want to be the most capable in a study group. You want to be with the individuals that have the best studying habits. So then you basically are gonna absorb and assimilate and make those habits your sequence of life. So that's my best advice. Perseverance. Any other question before we quit here today? Fantastic. So, what were there a mentor or experience doing resin that shaped the type of student you became? Yeah, you're gonna like for instance, my residents they have about 65 surgeons that they had to deal with during 3 years of residency. So a lot of individuals that you need to know their ins and outs, what they like, what they don't like, etc. But what you're gonna realize sometimes that individuals that are gonna train you sometimes they could be really hard. They could be really tough. They could be very demanding, but those are the ones that really want the best for you. So trying to take those criticisms well, not take it personal, uh, and understand that all this stuff is for patient care, is perfectly fine. And I still remember some of these attending surgeons that they trained me that, my God, I was terrified every single day during that month of rotation. And I still remember them to this day because I developed some really good skills because they would not cut any slack. And so take not everything that is sweet, nice, comfort is good. It's good to have individuals that they're gonna really drive you nuts because then you're gonna be more prepared for them. You're gonna probably study better. Probably you're gonna ask before you start that rotation because you don't want to have any headaches. So they're gonna get you uncomfortable, and in that way, if you're smart and you have grit, you're gonna prepare yourself for that. So with that said, I think I'm gonna be done for tonight. Back again, my email. There's another email that I have. This is my professional email. I would prefer if you guys use the this one that is in the bottom, because it's the one from the university, and I can copy Miss Kim Jong immediately to get you going on the virtual shadowing program. And what else? With that said, I would like to thank everyone for giving me this opportunity. I think this is I think that you guys just joining this at the end of the day is already a plus. It's a big commitment for me at the end of the day to be here with you guys, but just the fact of these questions, it's just great. And I hope that I hope I can continue helping you guys. Don't hesitate to reach out if you have any other whatever. Probably tomorrow you may start thinking about something else. Probably you're like, oh my God, I would like to be like Dr. Rodriguez. Okay, well then send me an email. It's take a long time. It's a long process. I mean, I've been in practice close to next year. It's gonna be 30 years in practice, and most people retire after 25 years of, and I still cannot see myself just quitting because I just like too much what I do. So, do I do the same thing I used to do? No, I don't like to deal with the emergency room anymore. I don't like to deal with bone trauma anymore. I like to deal with other stuff, and it's perfectly fine. So I think that I always tell my junior attendings and residents, emergency room care should be when you're a junior attending, 5 years into it, maybe six, but 10 years after you graduate, no, it's just it's too demanding, and that's kind of like the work-life balance that our field is not forcing you to be in the emergency room like orthopedics all the time. Even though we do orthopedics, we don't have to be in the emergency room call to pay bills like they do, and that's a huge advantage from my standpoint. Okay, because we do other stuff, not just bone fractures. Well, with that said, I would like to say thank you so much. Have a good night, everyone.
Doctor, before you leave, I'm so
Yeah, tell me.
sorry. I think that there are still a few unanswered questions in the chat. I can read them out loud for you if that
Let me
works.
see. Well, let me see. I thought that I did not miss anyone. Which one did I miss?
There's one called have you ever questioned your part or have you ever always loved your path?
Where's that one? That's the last one? Let me
No, there are actually like a lot of ones in the middle.
have, what was the question again?
Have
Have
you
you ever
always
questioned,
loved your path? Yeah.
Maria, sorry about that, Maria. Have you ever questioned your path or have you always loved it? Oh my God, that's a profound question. Um, you always gonna have doubts, always. You always gonna have doubts, okay? The only thing that I can tell you that you should not doubt is that you're gonna go through it. Okay. Other than that, yes, it's completely normal to say, what the heck? Why did I end up into this stuff? And I'm gonna tell you you think about this stuff when things are not going well. Especially, you have a patient that you do surgery, you did great, surgery went well. You tell the patient do not walk, and they screw things up. You're like, okay, this is not fun. Or you have a patient is not happy with what you did for whatever is the reason, and uh, and uh, and they're very upset in the clinic with you. You're like, okay, I don't need this. Why did I get into this stuff? But what you need to understand that those are going to be always instances that you can count with the fingers in one hand. The rest should be always looking at the end of the tunnel, the light, concentrate that you're going to be taking care of a ton of patients in your life that are going to be very grateful with what you do, and they're going to be very thankful. Okay. It's not uncommon every year out of the blue. I get a text message from a patient of mine. Doc, it had been 7 years since surgery. Oh my God, you restored the quality of life. Go into my website. You can see some of the testimonials are really good. And in that, and that's really what motivates you to keep moving forward, to always looking to do the best you can. But yeah, are you gonna have difficult times? Yes. Are you gonna question why you're in medicine? Yes. But understand that those are moments that you are gonna go through, and that should be no problem. That you're gonna it's expected. It's part of the job. Okay. Any other question that I missed, perhaps? Uh,
Yeah, I have a list. One of them was by Kristen, and it was, can you
what was that
explain,
again? Where is that one?
Kristen, it's, can you explain how you go about examining your patients, and how do you explain to them what bacteria or infections might be taking over their body?
Okay, so the short answer to that, come and rotate with me, and I would show you that. Okay, that's the long answer is during your medical training, you have your first 2 years that you're gonna learn about different type of bacteria, different type of antibiotics. You're gonna go through what is called a normal physical evaluation. You're gonna recognize what are the organ systems, what normally they do, and when they're not normal or they're compromised or you have a disease, what it gets manifested clinically, physically, that you know that things are not well for this patient, and you need to start having what is called a differential diagnosis. Give you an example. Swollen leg. Okay. If it's one leg that is swollen, not both limbs, it's a different diagnosis and differential diagnosis. If it's both limbs, it may be something that is liver related, kidney related. If it's one limb, it may be an obstruction of a vessel. It could be an infection only in that area. There could be your lymphatic, is another system of circulation, could be compromised. It could be an underlying fracture that the patient did not realize that had a fracture because it has neuropathy. That is a condition that affects patients with diabetes that compromise the sensation on both extremity. So there's a whole, that's the reason why you had to train for 2 years very well, reading all these chapters, articles, etc., and then going to the hospital and rotating internal medicine, family practice, anesthesia, anesthesia, infectious disease. Those rotations are gonna teach you what is normal and what is abnormal. And then, so then when you start doing your residency training, you can just be in charge of a clinic or be part of a clinic and being able to treat patients adequately, obviously with the supervision of an attending. So I hope that that helps. What other question do I have?
Yes. Do you ever get to work with an interdisciplinary medical teams? Like, if a patient comes in with a complex medical issue, how do you coordinate with other specialties to come up with a care plan that is best for the patient?
Yeah, so I answered that one. That's basically that when you're in a hospital, I use the example of a simple of being in the doctor's lounge, in which we talk about patients in the sense of I may have a patient that has darkening of the of their limb, and I think that they may have some obstruction. I may just go directly to the vascular surgical specialty in two methods. Either I would write immediately a note in the chart that that person would read, okay, will go to the room and examine the patient, but also without mentioning name. If I bump into that doctor in the doctor's lounge, say, hey, I have a patient that I put a consult for you to evaluate today because I think there's some things going on. Let me know what you think afterwards, and then they will call you back. So that's really the communication between medical teams. That's a circulation problem, but it may be an infection problem in another patient. So then I do the same thing with the infectious disease doctor. Another example, I may take a patient to the a patient comes through emergency room, fracture, but when it requires surgery, it requires all. It's a 57-year-old man, history of smoking. Patient had high blood pressure. I need to check. I need to do what is called a cardiac clearance. EKG, an electrocardiogram, be sure that everything is perfectly fine to go under anesthesia. So I may just talk to the cardiologist directly. Hey, I'm taking this patient to surgery, came in through the emergency room yesterday. It's a fracture, need to be stabilized right away. So that's really how important is to communicate with other medical teams. And in a hospital, you're forced to do it for the sake of patient care. When I answered that question, I also explained that when you're in private practice, you're more isolated. But when you practice in a hospital, by definition, when they call you, it may be a family practice doctor or an internist that comes, brings a patient with difficulty breathing, but at the same time, they have a swollen leg. And they may call you, and you want to be sure that you're not missing that this patient has a clot in the leg, because that clot is in the leg, clot may go to the lung and the patient can die. So then you need to put the patient in medication to break the clot. You need to know all the pharmacology. You need to know all the medication, how to break anticoagulants, it's called. If you're going to take someone to surgery and you think that they're going to have a lot of blood loss, well, you need to just get some blood before surgery. So that's really is the medical training of our field, podiatric medical training, and then you have the surgical training that gets part and attached to it. Any other question?
Yes, I see some questions in the chat.
Go for it.
Um, yeah. Do med school provide accommodations since school and colleges offer accommodations for students who qualify?
Medical schools, they have dorms. Yeah, they do have. That's what you mean? What do you mean with accommodations? I don't understand the question.
Alenjadar, do you know? Oh,
What?
mean it for students with disabilities.
Okay. Well, you know what? All the universities have accommodations for uh, any type of disability and all this stuff. Yeah, no doubt about it. Same way that any college, university will have, identical.
And the question by Chloe was, how did you study in medical field to stay on top of such a demanding field?
How do you stay on top of it?
Yes.
Don't leave things for the night before. Every single day you have to open the book, develop good reading habits. If you like something, even though you're not good on it, because you like it, you're gonna try to get good on it. So you have to really love science. You need to love to treat patients. That's one of the specific uh, things that when you go to an interview, they want to really get a feel for that. You really like to read because you have to be updated, and every single day there's new articles, new journals, new publications, new instrumentation. And so you need to stay updated and be always prepared to offer patients the best care possible.
Great answer. Thank you. And one question by one is, in severe diabetic foot infections, How do you determine the threshold between aggressive limb salvage and proceeding to amputation?
And so then one of the things that is if the area can be reconstructed or not. I think that that's really the main topic. If after you did, let's say that you have an infection to the lower extremity, the bone gets infected, the tendon gets infected, the capsule gets infected, you had to remove the infection. So think about it. You remove bone, tendon, muscle, what is left sometimes? So is if what is left is not functional, that the patient can really stand up and have a good quality of life, then we proceed with the amputation. That's the reason why it is so important that these infections get treated right away. But the problem is that most of the patients with diabetes, they have neuropathy, they don't have good sensation, so they don't have pain. And sometimes pain is the best indicator that something is not good. Okay. Um, and then just a minute laceration or break in the skin, you can lose the leg the following day. So these are really medical emergencies. They may have just a low-grade fever. They may think that they have in a flu. They may have a bit of a cut in the foot that they don't even know is there. And also, and they're in the hospital with the blood pressure is elevated, their heart rate is elevated, and we're trying to save the limb, and not just the limb, also save them from dying.
That makes sense. Um, what patient factors would make you avoid or delay TMR at the time of amputation? Vascular status, infection burden, or nerve quality?
All of them are very important. Like for instance, if someone comes in and have an infection and their limb has to be amputated, I cannot do the reconstruction when the limb is still under some sort of underlying infection. So I have to be sure that I clear all the infection, that the area looks clean, and also all the labs, the and the blood values are within normal.
Okay, and this is going to be the final question. Do you
Good,
notice
good,
it?
because you know
Yeah.
what? I was up by 5 o'clock in the morning, and
Oh my.
I'm losing here my mindset. Go ahead.
I'm so sorry.
No, I'm
Do you
joking right
notice?
now, but it's true. I had a long day. It's Friday.
Do you notice differences in phantom pain outcomes in patients with pre-existing anxiety, PTSD, or chronic pain syndromes? Or do you incorporate perioperative psychological screening?
Who asked me that question?
Juan?
Juan, we're gonna have to have a special conversation, you and me, okay? Because some these are some even better questions that some of my attending and residents ask me. So good for you. Thumbs up about that. Yes, if someone had been through a bad episode of their life, especially military personnel, there's a lot of documentation and publication on that end. They already have a mindset of a bad moment in their life, a bad injury. So they're going to the OR with fear. And not just that, it's been proven effectively that when you go through these moments of your life, there's areas in your brain that they develop in some way like scar. Okay. The thalamus is an area of your brain that is kind of like perceived pain. And the brain kind of like prints pain and doesn't want to let it go. So they need psychological treatment and they need medication that work on a central level to heal. So psychotherapy, pharmacotherapy, which means medication, um, is really important just to explain to them what we're gonna go through because surgery is another mental injury. Let's put it that way. So you have to really prep the patient. I like to put the patient in contact with other patients, kind of like a support system, and it's extremely beneficial on that end that they can really, how you say, benefit from understanding from someone else, because no matter how good I do explaining to patients what it's like, they it's really hard. It's extremely hard to explain. Sometimes the patients they do the best explaining to others what was like, fears, antibiotics that they we use, what kind of rehab, what kind of prosthesis, etc. So that's a very, very good question, and I believe that obviously the future, I don't know if you're aware of patient with amputation, is is another procedure. It's called osseous integration. And osseous integration, I have not done that procedure yet, but I think that I'm closer to really be able to get that procedure for my patient, which is a metallic rod that goes inside the leg that has a knob outside the stump, and the prosthesis attached to it like a robotic part. If you Google osseous integration implant for amputation, it will be there. And I have about 20 patients that are waiting for that device to be what is called FDA clear to be utilized in patient and have the insurance companies pay for it. What else? Anything else, or you think you guys are satisfied for today? You guys really got an hour and a half. This is amazing. I never done this an hour and a half on a Friday. So you guys are thumbs up for your perseverance and your motivation to know about medicine. Back again, let's not make this to be the last event. I can always, if you have any questions or whatever, I love the hands. Very nice, guys. Thank you for the hands going everywhere. And we're here to empower you, to make you feel more comfortable and more knowledgeable about what you are getting to, because it could be very confusing. So rotate, shadow, involve, get yourself in as many time as possible with other physicians, so then you can be able to see the good and the bad. The bad, like for instance, what is the bad? That you're gonna see me tired at the end of the day. The bad is that maybe at the end of the day, I just feel like just going home. Okay. In other profession, maybe at the end of the day, you have enough energy to just go bar hopping. But if you have patients the next day, you can't. So you need to understand that medicine, you need to have a lot of discipline. You have to have a lot of dedication, and you need to have a lot of perseverance. So with that said, if anyone can send me the list of all the emails of all the participants, and then I will send them to Kim Young to kind of rally you guys on the sense that maybe you can maybe have more events of this type with other type of physicians also. Okay. With that said, have a good night, everyone. And uh, whatever you guys need, one more time, keep me posted, and have a beautiful, blessed night. Bye bye, guys.
Thank you, Dr. Rodriguez. Thank you so much for joining, and it was great to hear from
Fantastic.
you.
Fantastic. Keep me posted.
Yeah. We'll just do a quick wrap-up presentation if anyone would like to stay. Okay, so here are three reflection questions I have for you. And it's basically, what was your favorite moment from today? What's one idea that you're most excited to explore next? And what's one key takeaway or idea that stood out to you the most? Feel free to answer these questions on the PHS Reflection website. Other than this, it would be great if you can share your insights on LinkedIn at Prehab Shadowing. Once again, if you're interested in being part of the Prehab Shadowing team, you're open to do so. You can do this by registering as a volunteer or joining a leadership team. Both the positions are 100% remote. Other than this, it would be really great if you guys could donate. You could do this by either donating money or through our newsletter, or you can also just volunteer. Don't forget to take the quiz after this session, which is basically a 10-question multiple choice quiz based on the presentation today. And you can do this by taking the shadowing assessment on the website. for Dr. Rodriguez. If you missed part of the session today, you don't have to worry. You can visit our YouTube channel at Pre-Hot Shadowing, and you can watch any of our previous sessions for free. Be sure to catch on our sessions every week by checking the PHS website or signing up to the newsletter. And thank you so much for joining. Thank you guys.